Stryker Medical is pleased to collaborate with you as you conduct your prevalence audit. The tool you're about to use meets the standard requirements for both pressure ulcers and physical restraint quality indicators for submission to most major databases, for example, NDNQI. The presentation you're about to view provides an overview of pressure ulcers and staging and the process of conducting the prevalence audit. The next few slides will review what a prevalence audit is, followed by an overview of the process of conducting a prevalence audit. A cross-sectional study examines the relationship between diseases or other variables of interest as they exist in a defined population at one particular time. A prevalence audit is a cross-sectional study. The snapshot picture you will be taking is of the skin of all the patients in your facility on one specific day. All patients in your facility will have their skin examined from head to toe. Dressings will need to be removed, as will all clothing. The purpose of this audit is to determine the number of pressure ulcers in your facility on one specific day. Certain groups of patients may be eliminated from the study, but these groups must be identified prior to the beginning of the study. Such groups may be patients in the maternity unit, the nursery, and/or the psychiatric unit. Individual patients may not be excluded. This is a study of pressure ulcers only. Acute wounds such as surgical wounds, vascular wounds such as arterial and venous, and neuropathic ulcers such as diabetic wounds are not to be included. Let us proceed to review the staging system, or the way that pressure ulcers are categorized. This system was updated by the National Pressure Ulcer Advisory Panel in 2007. A pressure ulcer is a localized injury to the skin and/or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear. A number of contributing or confounding factors are also associated with pressure ulcers. The significance of these factors is yet to be elucidated. Mechanical forces may be enough to close off the small blood vessels that circulate blood and nutrients. Without delivery of blood and removal of waste products, that area of the soft tissue may begin to die. The cause of pressure ulcers is primarily due to the mechanical force of pressure or pressure and shear. There are also factors that can cause a person to be at an increased risk of developing pressure ulcers, such as incontinence, immobility, comorbidities, and poor nutrition. Risk factors are identified by using a risk assessment tool. Risk assessment tools that you may be familiar with are the Braden, Norton, or Gosnell scale. The Braden scale is the most widely used tool and has been tested for reliability and validity across the care continuum. Pressure is defined as the force per unit area exerted perpendicular to the plane of interest. It is a vertical or direct downward pressure due to gravity. Point pressure in excess of capillary closure means that the force acting upon the body is great enough to occlude the flow of blood in the small vessels in the area of the body under pressure. This is an example of pressure over a bony prominence. Shear is the other primary mechanical force that contributes to the development of pressure ulcers. Shear can be defined as shear stress, which is the force per unit area exerted parallel to the plane of interest, and shear strain, which is defined as distortion or deformation of tissue as a result of shear stress. With shear acting upon the body, the capillaries and small blood vessels are pulled taut and occluded, which further impedes the flow of blood, nutrients, and waste products. With shear, tissue and blood vessels become more sensitive to the effects of pressure. Pressure and shear have an inverse relationship. As shear increases, the amount of pressure needed to occlude blood flow decreases. Therefore, increasing shear decreases the time the tissue can be subjected to pressure before ischemia develops. This is the most common example of shear: the patient with the head of the bed elevated. Skin remains adhered to the bed linens, the bony skeleton slides down, and the blood vessels in the soft tissue become taut and occluded, stopping the blood from flowing freely. The potential exists for capillary occlusion. We are going to briefly review how pressure ulcers are classified. Pressure ulcers are classified or staged by the depth of soft tissue that is involved in the process of tissue deterioration. The stage indicates the depth of anatomical tissue damage secondary to pressure and shear injury. Normal tissue is intact. Staging or classification of pressure ulcers is based on the anatomy of the skin. Wound classification is a way of determining the amount of soft tissue damage or the depth of tissue involvement, and it is related to the 3 layers of skin. This is an example of normal skin. Although there is no visual evidence of breakdown, the patient may be at risk. A Stage 1 pressure ulcer may be the most underassessed of all pressure ulcers. Stage 1 pressure ulcer is defined as intact skin with non-blanchable redness of a localized area, usually over a bony prominence. Darkly pigmented skin may not have visible blanching. Its color may differ from the surrounding area. There is no obvious break in the outer integrity. This is an example of a Stage 1 pressure ulcer. The area may be painful, firm, soft, warmer or cooler as compared to adjacent tissue. It is less easily distinguished than an obvious break in the skin, and often requires the sense of touch to assess thoroughly. Stage 1 may be difficult to detect in individuals with dark skin tones. It may indicate at-risk persons, or it may be a heralding sign of risk. A Stage 2 pressure ulcer is a partial thickness loss of dermis, presenting as a shallow open ulcer with a red-pink wound bed, without slough or bruising. Bruising indicates suspected deep tissue injury, or DTI. It is a superficial break in the skin integrity. It involves the outer epidermis and into the dermis. It is shallow, clean, moist, and has no odor. A patient with a Stage 2 pressure ulcer should have a treatment plan in place. This stage should not be used to describe skin tears, tape burns, incontinence-associated dermatitis, maceration, or excoriation. This is an example of how a Stage 2 pressure ulcer might appear. A Stage 2 can also present as an intact or open, ruptured, serum-filled blister. In the case of a blister, the break in the skin integrity is at the junction between the outer epidermis and the dermis, with an accumulation of wound fluid between the 2 layers. The roof of blisters should always be protected. A Stage 3 pressure ulcer is full-thickness tissue loss. Tissue involvement includes the outer epidermis, the dermis, and the subcutaneous layers. Subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed. Slough may be present, but does not obscure the depth of tissue loss. A Stage 3 pressure ulcer has measurable depth. It may have necrotic or dead or devitalized tissue. It may have an odor and/or significant drainage. A patient with a Stage 3 pressure ulcer should have an aggressive treatment plan in place. This is what a Stage 3 pressure ulcer might look like. The depth of a Stage 3 pressure ulcer varies by anatomical location. The bridge of the nose, ear, occiput, and malleolus do not have subcutaneous tissue, and Stage 3 ulcers can be shallow. In contrast, areas of significant adiposity can develop extremely deep Stage 3 pressure ulcers. Bone tendon is not visible or directly palpable. These are wounds that cause patients and caregivers much suffering. A patient with a Stage 3 pressure ulcer will have an aggressive treatment plan. Stage 4 pressure ulcer is full-thickness tissue loss with exposed bone, tendon, or muscle. Slough or eschar may be present on some parts of the wound bed. There is often undermining and tunneling. It involves all layers of the skin, the epidermis, the dermis, and the subcutaneous layers, with bone, muscle, and tendon exposed. A Stage 4 pressure ulcer demands much attention, with a very aggressive treatment protocol. This is how a Stage 4 pressure ulcer might appear. The depth of a stage 4 pressure ulcer varies by anatomical location. The bridge of the nose, ear, occiput, and malleolus do not have subcutaneous tissue, and these ulcers can be shallow. Stage 4 ulcers can extend into muscle and/or supporting structures, for example, fascia, tendon, or joint capsule, making osteomyelitis possible. Exposed bone tendon is visible or directly palpable. A stage 4 is totally debilitating and a most unfortunate event for the patient and for all those who are involved in the care of the patient. An unstageable pressure ulcer has full-thickness tissue loss in which the base of the ulcer is covered by slough and/or eschar. Slough is dead or necrotic tissue, which may be yellow, tan, gray, green, or brown. Eschar is also dead or necrotic tissue, which may be firm and tan, brown, or black. This is a wound bed that is covered by devitalized tissue. This is an example of an unstageable pressure ulcer covered by an eschar on the heel. Until enough slough or eschar is removed to expose the base of the wound, the true depth and therefore stage cannot be determined. You cannot stage the pressure ulcer because you do not know how deep the wound goes. Stable or dry, adherent, intact without erythema or fluctuance, eschar of the heels serves as the body's natural or biological cover and should not be removed. Suspected deep tissue injury, DTI, is a purple or maroon localized area of discolored intact skin or blood-filled blister due to damage of underlying soft tissue from pressure and/or shear. The area may be preceded by tissue that is painful, firm, mushy, boggy, warmer, or cooler as compared to adjacent tissue. Deep tissue injury, DTI, may be difficult to detect in individuals with dark skin tones. Evolution may include a thin blister over a dark wound bed. The wound may further evolve and become covered by thick eschar. Evolution may be rapid, exposing additional layers of tissue, even with optimal treatment.